Welcome to the PTUB Pod, an educational podcast created by paediatric trainees in the Southwest.
Featuring reviews of journal articles and interviews with authors and specialists.
Please note, these are our own opinions and do not substitute professional medical advice.
Thanks for listening.
Hi, I'm Lorna. I'm a paediatric trainee in the Severn region, and today I'm here with Dr Anirban Majumdar, a paediatric neurologist with a special interest in neuromuscular conditions. Dr Majumdar works at the Bristol Royal Hospital for Children. We're going to be discussing spinal muscular atrophy. Welcome to the podcast.
Thank you very much for your invitation.
To start with, can you explain a bit about yourself and how you developed an interest in neuromuscular conditions?
So I'm a pediatric neurologist. I've had an interest in neuromuscular disorders for almost 25, 30 years. I got into this field when I was doing my training in pediatrics. I became interested in neurology, and then as part of my training, I was placed at the Hammersmith Hospital in London, where under the auspices of Professor Montoni and Professor Victor Dubovitz, the neuromuscular service was delivered. Since I became a consultant, I've had a special interest in that field.
Brilliant. It's a very diverse field, and today specifically we're going to speak about a paper from the Archives of Disease in Childhood. The paper is entitled The Evolved Landscape of Spinal Muscular Atrophy Treatments and the Innovations in an Array of Disease-Modifying Treatments. And this is from the British Paediatric Neurology Association in 2023. What have been the major leaps forward in SMA treatment that you have seen in the course of your career?
So when I first started off way back in the year 2000, there were no effective treatments for spinal muscular atrophy type 1. Which is the severe form of spinal muscular atrophy, and infants diagnosed with that condition would die. 95% would die by the age of 2 years. The various treatments that were available were all supportive treatments. So it would enable these infants to survive, but they were certainly not curative and did not change their ultimate lifespan. And in 2016, 2017, the data around some of these disease-modifying treatments started to come out. And this data is based on almost 25 years worth of animal preclinical and clinical trial work. And the first treatment that was available for these infants with spinal muscular atrophy was nusinersen, an antisense oligonucleotide. Yes. And that was a transformative moment, certainly for these infants and certainly for my career. Because all throughout this time, when you had these infants who would inevitably die by the age of 2 years, suddenly with this drug, they were no longer dying and they were surviving and with a good quality of life. And here in Bristol, we gave our first patient with SMA type 1 nusinersen in 2017, and I'm pleased to say that she is still alive.
That's really amazing, and it's nice that you've been able to see the progress firsthand. You've mentioned nusinersen as one of the treatments. Can you explain a bit more about the disease-modifying treatments that are mentioned in the article?
So, in order to talk and explain a little bit about the different disease-modifying treatments in spinal muscular atrophy, it's worth understanding the actual disease itself, which is a genetic disease. It's worth clarifying a little bit of the terminology because for people not used to this field, it can get very confusing. So the disease is known as spinal muscular atrophy, SMA. And clinically, it is classified into 3 types. Type 1, which is the severe type, infantile type, where they die by the age of 2 without any treatment. Then you have milder forms, which are type 2, who never walk, and type 3, who may get to walking and sometimes subsequently lose their ability to walk. type 1's, the clinical classification is that they never get to sitting. So the clinical classification of spinal muscular atrophy is defined by the maximum motor milestones they acquire. Why is there this difference in the clinical phenotype, the three different clinical types? It's because of a gene known as the survival motor neuron gene, the SMN gene.
Yes.
And there are two SMN genes, SMN1 and SMN2. And this is where I emphasize that if you're not used to hearing this, SMA and SMN can get very confusing.
Of course.
SMA is the disease and SMN is the gene. The difference between SMN1 and SMN2 is one nucleotide. And this single change is responsible for the different characteristics of the gene. So SMN1 is absolutely vital for life. If you do not have SMN1, you cannot survive. And your survival depends on the copy numbers of SMN2.
Is there a thought process that, evolutionary speaking, this gene was almost put there as a backup?
I don't know. That's a theory. I don't know if there's any validity to that theory. But the interesting thing about SMN2 gene is that the more SMN2 copy numbers you have, the milder your spinal muscular atrophy phenotype. So typically what we see is children with SMA, spinal muscular atrophy, do not have SMN1. That's deleted. But if they have 2 copies of SMN2, they have the severe form.
Okay.
If they have 3 or 4 copies of SMN2, they have the intermediate form. And if they have 4 or more copies of SMN2, then they have the milder form. So this is the genotype-phenotype background to spinal muscular atrophy. So I suspect you'll probably ask me about the discovery of the gene and the subsequent treatments and how they came about.
Yes, go for it.
Well, in 1995, when the Paris group of Judith Melke discovered the difference between SMN1 and SMN2 and the fact that there was one nucleotide difference, it became very clear that the quickest way of fixing this would be is if you can change that one nucleotide or change the expression of that nucleotide and thereby affect either the SMN copy number or the SMN protein itself. And there are effectively 3 ways of doing that. First one is to replace SMN1 in its entirety. That is what gene therapy is about. And Zolgensma, onasamnogene aprocovec, to use its proper name,
Yes.
is the gene attached to an AAV9 viral vector which replaces the entire SMN1. But there are 2 other ways of delivering these disease-modifying treatments. The second, as we've already mentioned, is nusinersen. Nusinersen is an antisense oligonucleotide, which means it comes along and binds to a section before SMN2 gene, and it prevents the loss of an exon called exon 7 of the SMN. And that loss of the exon allows it to be included and therefore converting it to a fully functioning protein. And this works through modification of SMN2. I appreciate this is quite complicated and quite difficult to describe just by words. Often a simple diagram goes a long way. If I just finish off by telling you the third drug that's available, which is known as Evsidri, also known as Risdiplam. That is a small molecule, and that actually works by upregulating SMN2. So the 3 drugs we now know, if they are given at the right time, and the right time is as early as possible, preferably when the children with SMA are pre-symptomatic, they all work just as well as each other. The efficacy of all 3 drugs is essentially the same.
Which is very interesting.
which is interesting, and this has implications and ramifications, which we can maybe talk about later on. So just to come back, if you have an infant with spinal muscular atrophy type 1, severe infantile form of spinal muscular atrophy, you can give either Zolgensma gene therapy or nusinersen, antisense oligonucleotide, or risdiplam, an oral small molecule, and the outcome in terms of survival is equal. Now, these drugs haven't been compared to each other, but we know clinically that all three drugs work. We are very fortunate that in 2024 we now have availability through the NHS of all three drugs, which certainly makes my life as a clinician much easier, because I can then offer these drugs to the parents of the infant, who can then go away and have a think about it and make an informed choice.
So it's actually the parents who decide the type of medication that they want to use for their child.
With anything to do with treatment in pediatrics, we like to inform the parents and give them the opportunity to choose what they feel would be the best drug. Now here we have to be a little bit careful, because I have never come across a parent who actually knows about these drugs or will know about SMA, because this is just such a niche field. A parent may be an expert parent if they've had a previous child with SMA, but the vast majority of parents experiencing this for the first time will have no idea about SMA. Therefore, it is quite important for us to explain the disease, explain the treatments and the various options, and the pros and cons of each treatment modality.
And for onasemnogene abeparvovec, also known as Zolgensma, which, as we mentioned, is an adeno-associated viral vector to deliver gene therapy, there seem in the article to be very specific criteria for its use. So they have to be SMA type 1, under 12 months of age, using BiPAP for no more than 16 hours per day, and also that they must have 1, 2 or 3 copies of the SMN2 gene. Can you explain why those criteria are so specific?
Yes, all these disease-modifying treatments are very expensive. So Zolgensma gene therapy, the name you found quite difficult to pronounce, is one of the most expensive drugs on the planet. It is so this is perhaps where it's worth talking about the pros and cons of these drugs, keeping at the back of our mind that all three drugs work. So if all three drugs work, how does one choose as a clinician what is the best drug to give to a child, and how does a parent agree with your decision?
Yes.
So first of all, we have some protocols and guidelines. So one of our areas which we have worked on quite a lot with both NHS England is to clarify the inclusion criteria for infants to receive gene therapy. There are advantages to gene therapy. It is a one-off IV infusion given over 1 hour. And once the infusion is given, then there is a period of about 3 months of regular blood test monitoring, and giving immunosuppressants such as prednisolone to stop the chronic hepatitis, myositis, cardiomyositis that they may develop. So although the beauty of gene therapy is that it's a one-shot treatment, it is no walk in the park, because these children often are, by definition, they have SMA1, so they're pretty sick anyway. They may be in and out of the intensive care unit because they're getting regular chest infections, have swallowing difficulties, bulbar problems, recurrent aspirations. And giving gene therapy means subjecting them to several months' worth of immunosuppressants. You can see how one would have to think very carefully about advising gene therapy for these infants.
Yes.
this is where having 3 disease-modifying treatments are extremely handy, because if the child is quite fragile, and you mentioned the ventilator parameters, for example, if the child is receiving 14 hours a day of ventilation in and out of the intensive care unit, one would think very, very carefully before one advises having gene therapy and the subsequent immunosuppressive treatment. Why not consider one of the other disease-modifying treatments, such as nusinersen, which does not need long-term immunosuppressions, or even risdiplam, which is an oral drug, a syrup, which does not need any long-term immunosuppression.
Is that because of the way they're delivered to the cells?
Absolutely, yeah. So gene therapy, the fact that you're giving an adeno-associated virus, AAV, means that the body mounts a reaction to that virus, and effectively this virus doesn't just go to the nerve cells, it goes to all the other cells in the body. It is particularly susceptible to going to certain organs. It seems to have this tissue tropism, the AAV9 virus, and therefore predominantly tends to go to the liver, where the liver mounts a reaction, and that's why these children who've received gene therapy will inevitably develop a chronic hepatitis. You mitigate that, you treat that by giving steroids. So sometimes we have to make the very difficult decision and actually tell some families that their infant is not a candidate for gene therapy, but would be better off having nusinersen and risdiplam. Okay. That is sometimes quite a difficult discussion to have, because the perception in around families, thanks to lots of little articles and things on social media, is that gene therapy is a miracle cure.
Yes.
And this is a problem, because first of all, it's not a miracle, it's science. And secondly, it's not a cure, because it's a disease-modifying treatment. It hasn't cured spinal muscular atrophy. It has, by its disease-modifying mode of action, converted it into a milder form of spinal muscular atrophy.
That makes
so
sense.
We are always having to have this discussion, which is a very difficult and fraught discussion with the parents, to explain to them that all these drugs are disease-modifying, not curative.
Yes. You've actually touched on what I was going to ask you next about this idea of a cure, and how parents can focus on that aspect for their child. So I think disease modification is actually a really good term, because it describes well what all these treatments are achieving. And unfortunately, the origin of the disease, the genetic basis, is not changed permanently. At least we can't be certain about that yet with the gene therapy treatment. And now could you expand a bit on the data that we now have for these children who are receiving treatment in the first year of life? How are they doing in the long term?
Yeah, so worldwide, there's been about 3,000 children with spinal muscular atrophy type 1, severe infantile form, who have received gene therapy. I cannot quote you the numbers who are alive and those who have died. There has certainly been a few deaths, but the vast majority are alive. What I can quote you are the numbers from the UK. So there was a Lancet publication from our group together with the other 3 centres who all do gene therapy infusions, and we published approximately 100 infants who received Zolgensma. And the data shows that this is a very, very effective drug, and provided you give this drug to infants as early as possible, the better the outcome is. And this is perhaps one thing I really would like to emphasize. In the past, clinicians, laboratories would consider SMA, but wouldn't consider it as an urgent condition that needs identification and treatment as soon as possible. Those days are long gone.
Good.
Nowadays, if you suspect SMA, you should be asking for an urgent genetic test, which most labs should be able to turn around within 48 to 72 hours.
Wow.
It is actually an emergency because every day that goes by, the infants lose more and more neurons, which they will never get back. So, if you have a suspected SMA on Monday, I would expect you to pick up the phone, get the kid in ASAP, undertake the genetic test, and if the genetic test is confirmed, to give your friendly pediatric neurologist at your local center a call. Because potentially that child, as soon as the genetics confirms SMA within 48 to 72 hours, you could start off a disease-modifying treatment. And the quickest one to start off is you start them on risdiplam, oral medication, small molecule. Most pharmacists keep a bottle of risdiplam on their shelves. You start that off, and then you have a little bit of time on your hands. That then gives you several weeks for you to work out whether you're going to continue with risdiplam, you're going to change it to nusinersen, or you're going to give a one-off treatment of gene therapy. And the parents have the luxury of taking their time, gathering the information, digesting it, and taking a joint decision with yourself about what the appropriate treatment is.
That's really helpful, actually, because I think for trainees, that's the sort of perhaps the most important point, that, identifying it early and signposting to a paediatric neurologist ASAP. And it's really nice for parents that there is, 3 different modalities of treatment. So there is that option to start treatment quickly and then build upon that and change it as needed. So it seems that you're saying that they can actually start on one treatment and it's okay to change to a different treatment.
Yes, so once a treatment has gone in, such as nusinersen or risdiplam, you can change. That is allowed. What we cannot do in the UK at the moment is use dual therapy.
Okay.
However, if you give gene therapy, it's a one-off. Once you've had gene therapy, there is really no need for a second agent such as nusinersen or risdiplam, unless you can clinically show that the gene therapy isn't working. Perhaps I could just add here, I cannot emphasize the importance of the speed and the promptness of making a diagnosis. Because children with SMA type 1 lose their neurons very, very fast, their anterior horn cells very fast. And literally a week can mean the difference between the child having a potential long-term outcome with treatment of being a walker versus having a potential long-term outcome with treatment of being a non-walker.
Yeah.
So it is really quite important trying to get in as early as possible. The ideal patient is the patient where you know, because they've had tests either through amniocentesis or fetal DNA, that they have SMA already, or you know that they're likely to get SMA because they've had a brother or sister with SMA. Yeah. You basically need to catch them as soon after birth as possible and give them the treatment. Those are the pre-symptomatic children, and they do amazingly well. A pre-symptomatic SMA type 1 treated with any of the 3 drugs will essentially become a walker. And if I cast your mind back to what I first said when I first started in this, SMA untreated would die by the age of 2.
Yeah, it's a stark difference.
It's a complete game changer.
Looking at the article, it mentions the November 2022 data cut that more patients were receiving nusinersen, so it's 275 at that point were receiving nusinersen, compared to 120 on risdiplam and 83 having onasemnogene abipavovec. Can you explain whether that's still the case?
So the reason the numbers look the way they do is because from 2017 up to 2021, the only drug that was funded by the NHS for children with SMA type 1 and all SMA types was nusinersen. So if you had a diagnosis of SMA, you were a candidate to receive nusinersen. And that's why the numbers are quite large in that data cut. But from 2021, we have had on the NHS the availability of gene therapy. And very soon afterwards, we also had the availability of risdiplam. And therefore, I think if you did the data cut in, say, 2-3 years' time, you'll find the numbers of risdiplam have increased. The numbers of children receiving Zolgensma gene therapy are now well into about 120. Nusinersen, what I believe is probably plateaued. It may have something to do with the fact that nusinersen has to be given intrathecally, and the drug dosage regime for nusinersen is that it needs to be loaded, which means in the first 2 months, first 60 days, you have to give 4 loading doses, and subsequently you maintain nusinersen by giving an intrathecal dose once every 4 months.
Is there an evidence base for this chosen interval?
So the timings for intrathecal nusinersen is all dependent on the half-life of the drug and its time and pharmacokinetics once it's in the intrathecal space. And again, that's why an oral drug like risdiplam you have to give every day, twice a day, because of the half-life and the bioavailability and the tissue distribution. And also, gene therapy is a completely different ballgame because it's a one-off dose. And it lasts, as far as we know, probably up to 8 to 10 years. That's the data that seems to be coming from the non-human primate who have received AAV9 therapy. And the earliest data we have for gene therapy, it was really given by those who undertook the initial pivotal trials, was back in 2015, 2016. So we are coming up to 10 years worth of data. But this is a question that nobody really knows the answer to, is how long will the gene therapy last, and will it ever need to be repeated in the future?
How are they actually testing that? How often are they monitoring these individuals?
So the children who receive any of these disease-modifying treatments should all be plugged into the neuromuscular clinic, where the standards of care suggest that they should be seen by the specialist once every 6 months. Those who have received gene therapy in the first year after receiving gene therapy, they tend to have approximately a dozen blood tests, and they are seen once every 3 months. So there's quite a lot of intense monitoring that goes on.
That makes sense. If we go back to what you mentioned earlier, the fact that all the treatments successfully target the intended part of the body, which is fascinating really, as you're giving 3 different treatments via 3 different routes of administration. How does this work? Do we know? Mm-hmm.
So all cells require survival motor neuron, SMN. Gene therapy, which is delivered by adeno-associated virus AAV9, the AAV9 gets into virtually every cell of the body. Therefore, if the gene is attached to the AAV9, this gene will get to virtually every cell of the body.
But some cells of the body are dividing faster than others. Forgive me for my ignorance, but I wasn't sure whether the anterior horn cells have any capacity for regeneration.
So with the anterior horn cells, or with any neurons, once they die, they are unsalvageable. But we think that before they die, they become sick. They just don't function as well. And replacing the missing SMN protein allows them to function normally. That is all theory. There's a lot of people doing work to try and work that out, but it's an area which is still under a lot of discussion, investigation, and debate. So going back to the question about bioavailability, so we've talked a little bit about how the AAV9 can get to all cells of your body. So begs the question, how does nusinersen work? Because you're giving it into the intrathecal space, which is really where the anterior horn cells are. Well, this is why nusinersen, we seem to think, affects the anterior horn cells and protects them, and therefore the motor outcome with nusinersen seems to be excellent. Whereas we've noticed this, and again, I have to emphasize that this is anecdotal, this is not peer-reviewed data. We seem to find that kids with nusinersen perhaps don't have as good bulbar function as we see with other children, but their motor function seems to be excellent. And also with risdiplam, which is an oral small molecule, because it's a small molecule, it seems to get absorbed very high up in your alimentary tract, and therefore it seems to work very well in terms of motor function, but it also seems to improve bulbar function, perhaps better than nusinersen. Again, anecdotal evidence, but we wonder if this is because of the nature of these drugs being taken into the body, one in the intrathecal space, one in the alimentary tract quite high up. These are areas which we haven't quite worked out yet, but this is what seems to be happening.
That's very interesting. The article also mentions the SMA REACH study, and Bristol Children's Hospital is one of the centres for this study. We've spoken a lot already about the outcomes for these children and how they've improved, but is there anything else you've in particular learned from contributing to this study and following the children up?
So SMA REACH is essentially a audit. It's a national database which all the centres who deal with children with SMA contribute data to. It started off its life about 25, 30 years ago, essentially as a national audit, but it has now become a national audit and research database with its own governance, infrastructure, and rules. There are probably about 23 to 25 children's hospitals around the UK which all contribute data to SMA REACH. And it's only through contributing data to SMA REACH will we have any chance of working out whether one drug is better than the other. And I came to this realization by speaking to some of my North American colleagues, where they do not have a central research audit database. So each state collects its own information. And therefore, the Americans will have no chance of working out which drug is better than the other. But here in the UK, thanks to the work of SMA REACH, we've got some hope of actually coming up with some answers like that. Every child with SMA, whether they receive a drug or whether they just receive standards of care, whatever they are, their data every 6 months gets collected and gets inputted into this database.
One of the concerns that parents sometimes have is about their access to funding for these medications in the future. Is that something we need to worry about in this country?
No. In this country, we're very fortunate because the NHS is able to provide the funding for all 3 drugs. It is an issue for us when patients come from abroad who may have received a drug, and in this country they are then trying to source funding to keep these drugs going, and because they've come from abroad or for various rules and regulations, they cannot access the drug through the NHS. That then becomes a really difficult issue as to whether the NHS should be funding these patients, but that's a different question.
Yeah, okay. But it's reassuring that parents, for the most part, aren't having to worry about accessing these medications. For all the treatment modalities we've spoken about, great leaps forward have been made as part of the research in developing these drugs. If in the future our antenatal and neonatal detection of SMA is better, do you still think we will be using these drugs?
The simple answer to your question is yes, absolutely. These treatments are here to stay. We have hundreds of kids on these treatments. The NHS is not going to stop this treatment suddenly because it runs out of funding. That's not going to happen. I think the more interesting question which you've touched on is this prospect of newborn screening. The UK, unfortunately, is the poor man of Europe in the sense we still do not have newborn screening for spinal muscular atrophy. It is an embarrassment because the rest of Europe does. Vast majority of the states in North America and Canada have newborn screening. In fact, there are, the last count, about 20 countries around the world who have implemented newborn screening. Newborn screening is the only way of catching the vast majority of pre-symptomatic SMAs. If you catch pre-symptomatic SMAs and you give them prompt disease-modifying treatment, they will live and they will get probably to walking. That thereby saves a huge amount of costs, trouble and heartache. And the fact that even after all this evidence, the UK continue to drag their feet by not having newborn screening for SMA is frankly just very embarrassing.
Yeah, I had no idea that most of the other countries in the vicinity were already doing that. Finally, anything else interesting you'd like to tell us about SMA and the revolution in treating it?
So the key question everybody seems to be asking now is, we know monotherapy works, but is dual therapy going to be better than monotherapy? There's a couple of research projects which are happening in some other countries in Europe, looking at children who have received gene therapy and then whether they get additional nusinersen or additional risdiplam and whether they have a better outcome than treatment with Zolgensma gene therapy. So that is going to be the question that we're trying to answer at the moment. In the UK, dual therapy is not funded by the NHS. However, in the States, where funding routes are different, the hospitals and the doctors may and often are in a position to give dual therapy to their children. And this is where the problem arises. If you're giving dual therapy to a child with SMA, you really need to collect the data in order to understand whether it's helping in addition to monotherapy. And I do not think the physicians in the States are doing that in a systematic fashion, as we would be because we are part of SMA Reach UK. So that is the next area in SMA. And of course, we must remember that these drugs do not cure SMA. It's about treatments and adhering to the standards of care. And just giving this drug and not doing all the other things that children with SMA need, such as looking after their breathing, looking after their feeding, checking their weight, making sure they don't have fractures, making sure they don't have osteoporosis, sorting out their wheelchair, sorting out their spine, sorting out their hips. If you don't do all this, then really the time, money, and effort you've spent giving the treatment perhaps is not best utilized as it could be. So the standards of care and making sure these children are seen regularly with a team who know what they're doing with SMA is absolutely vital.
Brilliant. So it's still very much an MDT approach.
Absolutely.
For these children.
Yeah.
I think we will conclude there. It's been amazing to discuss this progress that's been made in genomic medicine in recent years, and I'm sure there's a lot to look forward to. The link to the article and any resources are in the show notes. As per tradition, do you have a book recommendation for us today?
Medical or non-medical?
Usually, I think I'd prefer to hear non-medical.
So the most recent book that I enjoyed was Yellowface. That's a very good read, very entertaining, has nothing to do with medicine and everything to do with chicanery and backstabbing and politics of publishing, which I enjoyed very much. I also quite like history, read a lot of history. I'm currently going through Antony Beevor's book on the Spanish Civil War, which is highly recommended, but perhaps a lot of hard work.
Very good. Thank you so much for joining me and teaching me loads about SMA. It's been a really in-depth discussion, so thank you.
It's been a pleasure. Thank you very much for inviting me.